have members calling in and on the phone. So as a reminder, due to the continuing issues related to COVID-19, we have some new meeting protocols in place for the 2020 interim session. Remote access is allowed to all meetings for the interim. Members are provided the information prior to the meeting on how to access the meeting remotely. The meeting materials were put out online earlier this week and made available for downloading. At this time, we'll have the secretary call the roll. Members, you will need to indicate whether you are present in person, remote from district, or remote from your office.
Senator Rocky Adams, Senator Carroll, Senator McGarvey, Senator Meredith, Representative Bowling,
Here in person.
Representative Frazier, Representative Gibbons-Prunty,
Here in person.
Representative Raymond, Representative Sheldon,
Here from home.
Representative Stevenson, Representative Weber,
Here in person.
Representative Westrom,
Here in person.
Ma'am, are you in your annex office or district?
No, my annex office.
Thank you. Representative Wilner,
I'm here in my district.
Senator Humphreys, Senator McDaniel, Representative Moser, Representative Reed, Representative Rudy, Co-Chair Bentley, Chair Castle.
Here in person. And if those who have called in, if you can mute your phones when you're not speaking, it'll keep a lot of background noise down for us as well. So next, we will have approval of the minutes from the June 3rd meeting. Do I hear a motion? Have a motion by Senator Meredith and a second by Chairman Bentley. Okay, at this time, we are going to get an update from Secretary Freelander and Eric Lowry, the Budget Director with the Cabinet for Health and Family Services. They will be giving us an update on the Cabinet's funding and expenditures for the COVID-19 related services. So if you all can announce yourself for the record, and the floor is yours.
Thank you. Eric Friedlander, Secretary to Health and Family Services Cabinet.
Eric Lowry, Budget Director for Health and Family Services.
So we presented much of this information last month. There are some updates. I'm happy to go over some of the differences and really happy to allow time for as many questions as you all have and happy to answer what I can. The federal funding acts you have there, you've seen that, I know. The preparedness response supplemental appropriation acts, we're actually up to about, a little over 300,000 as of today. Is that right, Eric?
I believe so.
Okay.
Yes. 300 million.
Yeah. And then the Family First Act, which is the non-Medicaid, the Family First, which is the Medicaid, that's the increased FMAP. The Relief and Economic Security Act, again, that's gone to help a lot of different folks, and Paycheck Protection, which we don't really, that's not one that we necessarily participate in terribly directly, but that's what we have. Just to go through this really quickly, again, happy to take questions as we go. Some of the emergency response pieces. Eric, do you have anything you want to add on this one?
No, I would just add on all of the expenditures in this slide deck are dependent on when the invoices have actually been brought into the cabinet. A lot of our work is done at the community level, and there's always a mixture of maximizing our current funding versus our coronavirus funding on timeframes and making sure we stretch the dollars as far as we can. So the expenditures are not necessarily representative at this point of what work has been done at the community level.
Thanks, Eric. On the Families First Response Act, we've had the award on the 3.2 million. I think this is one that really enjoyed working with folks on this. We delivered our millionth meal since the pandemic began on March 6th. So a lot of community partners have stepped up, like all over the state, with volunteers, restaurants, meat processors. A lot of folks have helped provide food for seniors. People have been going out and delivering. It's probably one of my favorite parts of this story that we're going to have, which is coming through this, how many people have pitched in across the Commonwealth. It's been really great to see. Our temporary increase for the Medicaid medical percentage, again, that just to clarify again, that means that we can't make any changes in our eligibility really moving forward. We can't reduce our eligibility. We can't increase co-pays. There are requirements for receiving that enhanced rate for Medicaid, which we comply with all, but just know that we're seeing an increase in our Medicaid enrollment. I think as of today, we're a little over 1.5 million, which is an increase of about 170,000, somewhere in there, over pre-COVID Medicaid enrollment. So this is important, and I think it was anticipated that we'd see increased enrollment in Medicaid with increased unemployment and things like that. It's just, and we're seeing it here in Kentucky. The Aid, Relief, and Economic Security Act. There are different places where we spend money, the family caregiver program, some of the home delivered meals pieces I've talked about, no wrong door funding, which really helps us in what's called our, it's called ADRC, Aging Disability Resource Centers. And so it's how folks can get services, and they call in, and you can get a lot of different services that way. So these are pieces that we spent that have to do with personnel and with services. Anything you want to add here, Eric? There are a lot of, okay. In public health, we're working on really increasing our laboratory capacity, and that is, we have a machine that is really sensitive, but it doesn't have much throughput, much volume, and so some of this funding is going to be used to increase that capacity. We've also then, of course, provided some money to local health departments, as you all I know have heard. And then there are different funds that have come through directly to providers. We know rural health clinics, hospitals, nursing homes, there's federal money that has flowed basically directly from the federal government to these healthcare entities. We have the overall number, but we don't have the specific number for each individual entity at this point. We're still kind of waiting and working with the federal government to see if they'll disclose some of that. So anything, Eric, you want to add? Okay. We've also then distributed money through the child care block grant. Some of that are the stipends that you've heard about on child care. We also then, some of this money, the low-income heating and energy assistance program, I get reports from, and I'm happy to share this with you, but basically every community action, I get basically a daily report that says how much of the funding is spent, which community action spent it, and what's the percentage. So they have what they're calling a summer crisis period and a summer cooling period. So folks who are behind on utilities can get assistance through their local community action agencies. And this is a part of what they do. The other thing that and again, happy to provide this to you all, they send a little plan on how they're going to use their funds that are coming through the CARES Act. Most of this is emergency relief, rental assistance. A couple of folks are doing some interesting things with some mobile units. And again, happy to provide this. It's really just how they spend their money through the local community action agencies. It's pretty straightforward. Nothing really surprising here. Like I say, a couple of things that are interesting. Eric, anything you want to add? Okay. Within the Paycheck Protection Program, again, there's this kind of money for epidemiology and laboratory capacity. You'll notice we changed the name a little bit on this to be a little more clear. What this money can't pay for is like that individual testing, right? It is more about capacity building and population surveillance. So they're just trying to make it a little more clear about what this funding is for. We're using some of the CARES dollars directly and asking for that to pay for some of the testing that's happening in some of the nursing facilities and places like that where we've actually provided some of the testing. Anything you want to add there? So with that, I know it's a quick overview. We'll have more. I think we're scheduled to come back in
Probably 2 months, probably
maybe a
sooner.
month or two to give you where we are on closeout. Happy to do that, and then we'll have some more information on where the CARES funding is spent, and really happy to answer any questions you all might have.
Secretary, thank you for your presentation. And members, we're going to do questions for those who are in person first, and then those who are listening online or have called in, we will then ask you to announce yourself when you ask your question. I think our computer is down. Secretary, Senator Meredith has a question.
I do, and thank you for being here, and I sincerely appreciate the effort you're putting into this. I know it's very trying times. I think I'm focusing more on the budget for this next year, trying to wrap our arms around that. And we had testimony from Commissioner Lee at our Medicaid Oversight Committee meeting, and she mentioned we'd add $170,000. And I kind of asked, what's the price tag? And she said, well, we really don't know at this point, that we're okay for 2020, but 2021 will be a challenge. So we're kind of framing that. And my concern is that if we add 170,000 people, if we're not making our providers whole, then we're not going to have a healthcare delivery system take care of the 170,000 to begin with. And I have a lot of particular interest, but I think those that are most in danger at this point may be our hospitals, because we heard testimony that we had 12 that were considered financially challenged, and now maybe that's 20. But I'm probably more concerned about our nursing homes because they really have seen incurred the brunt of the dollars here. So I know they got a $270 stipend to take care of COVID-19 patients. Do you know how much we paid out totally under that?
It's less than $1 million. What we thought, and talking with the association and talking with their financial folks, what's happened is when folks test positive for COVID, if they're Medicare, if they're dually eligible, they get a much better rate if they go with Medicare as opposed to that $270. It's even higher than that $270 add-on. So a lot of the folks that and you know, maximizing that income stream, it's better than to charge Medicare than it is to charge them Medicaid that additional rate. There's some folks who are not dually eligible. There's not very many of those. So that's why it isn't as large as I had hoped when we put that in place.
Ms. Chair, follow up to that. The reason I asked that question first is I know that they're incurring tremendous expense on the PPE side. By their estimates, it's about $5.8 million per month. And the $270 that they're getting now for those patients obviously not going to cover that. And I guess I'm concerned about all of our healthcare providers building inventory for the future of PPE. You know, we're taking care of the people now, but what happens when we hit this next wave? So if this number is correct, then we're looking at $60 million more from the nursing home industry that's above and beyond the expense they have at present. Are we acknowledging that in any way, we being the cabinet and Medicaid? Because they're going to need additional financial resources if we're going to survive this thing and have the services available to people that we obviously need.
It's one of the reasons we're trying to figure out how much the federal government is sending directly, because we do need to understand what that is, and that's not a number we've been able to get. The other piece that we have done that we know has had impact, because we can look at our Medicaid outlays to nursing facilities from across months, and we see that it's increasing. So what we believe we see is that when we shortened the eligibility time, when folks could come in under that short form, We decreased the time that it could have taken months to like a week, so that more folks can get eligible more quickly. We believe, although I do not have a dollar figure for you, we believe that had a much larger impact. The other piece that we think is hope has helped is that we have provided some direct pieces on PPE as well as some direct help on testing. We're looking at now how we're going to be able to support that on an ongoing basis, because I feel like we should, but we don't have that finalized yet. In terms of Medicaid moving forward into 21, I think we're looking at coming up with some estimates in September, are kind of back of the envelope look at 21, and this, don't hold me to this, but it depends how long the increased FMAP rate hangs on. If it hangs on for 6 months to the end of the year, we're probably in much better shape than if it doesn't. If it ends quickly, then we're not in good shape. So really, I think that's a fair way to say it. The thing for this group to keep an eye on is how long that increased FMAP rate is held in place. The longer it is, kind of the better off we're going to be. Like I say, if it's short, we're in trouble.
And you answered my last question, is that, when can we look for numbers? Because again, my concern, if we wait till January to start formulating the budget for 2021, we're going to be way behind the 8 ball. So we need to make sure we continue to have dialogue like we're having today and try to wrap our arms around what the cost is going to be, because I know it's going to be enormous and not sure where the funding is going to come from. And certainly we're hoping the federal government will step up. But again, they can't continue to print money. At some point in time, we're going to be on our own, and I just don't know when that pivotal point is. But we need to make sure that we continue to communicate. So I appreciate you being here.
Yes, sir.
Also want to commend you for shortening the time for eligibility for Medicaid. That certainly made sense in this crisis, and I appreciate that.
The other reason that we're trying to figure out how to project some of those costs, the presumptive eligibility piece, what we did that short form for folks. We put most of those folks into fee-for-service. That lengthens the time of when we're going to see a ramp up on billing. So we didn't put those folks directly into MCOs. And we did that sort of to see the difference, right? As well as when comes time to do anything with MCOs. We're actually now larger than some of our smallest MCOs in terms of fee-for-service, but that gets us some experience in that realm where we just haven't had a lot of it recently. So,
Well, that's why I was a little bit surprised when Commissioner Lee said we're all right for 2020, because I know we're incurring expenses now, but we're incurring expenses and paying for things that we haven't earned money on yet. So glad we're going to make it through 2020, but 2021 will certainly be a challenge. But
Yes, it will.
thank you. I appreciate the information. Thank you, Mr. Chair.
Secretary, before we change the subject, to follow up on Senator Meredith's question, so of the $436 million of the increased FMAP, how much was spent to date on the beneficiary and provider type? I didn't see that in the presentation. I didn't think we were going through it.
we can provide that for you.
Okay.
We spent about $250. Yeah, I think it's in there, $250 around, but we can break that down by provider type and.
Okay,
and I'll
yeah.
look
If you can get that to me, it'd be wonderful. Thank you.
We will do that.
50.1.
Yeah.
As of last week.
Okay. So we'll get the
Yes,
breakdown.
we can provide it by provider type.
Okay. All right. Representative Moser has a question.
Yes, thank you, Mr. Chair. Thank you for your presentation. I appreciate the ongoing dialogue on all of this, and I know it's really complicated, and, we're spending federal dollars now that, and extending deadlines for things that we know are helpful now and probably will be helpful moving into the future. But it's really, to Senator Meredith's point, very difficult to budget for all of this. But I have a specific question really about testing, and, the governor is encouraging folks to get tested. It's a good idea, I suppose. But if you could elaborate a little bit more on the epidemiology and lab capacity and kind of where these subsidies specifically are going, because I don't know that there's a lot of clarity to individuals who are looking to get tested on who's paying and what is the coverage, and I don't know what to tell people when they ask me whether or not it's covered for them. And then there's some issues with locations and these pop-up clinics and, you know, knowing when they're in certain locations. And I don't know that there's a whole lot of consistent information for individuals. Can you just speak to that?
Sure. I will let you all know I'm getting tested about once every 3 weeks. It just seems like the right pace, particularly when you think about at least maybe a 14-day incubation period. It just seems to be about right. But that's Eric. And the Secretary's Office staff. We're doing that. We're going down to our local health department, which is just down the hill from the CHFS, and getting tested there. So, to answer your question, the epidemiology piece is eventually different tests are going to become more important. I'm not a physician, but they're tests that really look for if you've ever been infected, right, or had COVID. Those tests will become more important over time as more of our population starts to be impacted or have gone through an infection period with COVID. So some of that has to do with that population kind of test and population health, and then it's building that capacity. So the grant really about building capacity is about some of that epidemiological population-based sort of tracking, not an individual test. The other piece is to try to provide more equipment. Again, to local health departments as it impacts our own laboratory to build capacity over time in that way, so that hopefully when we maybe never have this again, another 100 years would be just fine with me. But we'll have some more capacity to be able to really ramp up our tests much more quickly than we've been able to. In terms of individual testing, what I've done is when folks have contacted me, I've referred them to the COVID-19 website, to some of those locations where folks can go. I realize they're probably not enough for everybody, but that's really been my best advice, because I feel like then you can look, you can schedule, you can try to do some of that on your own. And folks who've been able to do that, at least that have then communicated back to me, that's worked okay for them. And so I think that's, if I were giving somebody advice, I would tell them to go to the website, look up where the locations are, and make an appointment that way. And then that gets covered either through your insurance, but that's how that is happening. That's been my best advice to people. It seems to be the most clear way to direct folks. So that's what I've been saying.
Yeah, I mean, that's what I've done for the most part, is directing, folks to the website. But I was on the website last night because of one of our colleagues actually in the legislature was trying to get tested yesterday. And they called and were told that they didn't need to make an appointment. Or I think on the website it said they didn't need to make an appointment. They got there, they had to make an appointment. There was no one in line. It was a drive-through center.
Yeah.
And she was told that she had to make an appointment even though there was no one there. So I think that, I know that you can't control what individual urgent cares do or don't do, but there's just not a lot of consistency. So
We'll work on that communication.
Yeah.
That's good feedback. Thank you.
All right, thanks.
Thank you, Representative Mildred. At this time, Representative Prunty has a question.
I actually have three. Can you indulge me? First, I want to echo Senator Meredith's comments about the nursing homes, because my nursing homes, when they were contacting me, said that the stipend didn't cover, it only covered active patients, people who'd been diagnosed, when they had to get extra PPE for all the employees and just in case for everybody. And so just to kind of keep that on the radar. My first question is, you've got, in the report, you've got several dashes like there were no expenditures, and I'm assuming there have been expenditures. Is there reasons why those aren't reported right now, or?
Again, these are representative of when expenditures actually hit our system.
Okay.
With the work being done by our community partners, they may not have invoiced us yet, or the invoice may be waiting to be paid.
Okay, well, I can understand that it's below, and I'm glad it's below, because then you've got some more to cover it. But when there's absolutely no expenditures, it just seems a little, like you would have spent something, but, okay. And then number two, with the increase in the enrollment, are you seeing numbers going down as people are going to work? Because, I mean,
Not yet. What we've seen is, there was a period of time when we were getting about 8,000 a week, that jumped to then, past month or so, to about 12,000. We have not seen a decrease yet. What was last week?
Last week was between 6,000 and 7,000.
So
So
6,000 and 7,000, so so the rate of increase may be slowing,
okay.
but we're still seeing more folks.
I just feel like eventually, hopefully, it's going to go back down because hopefully they're getting insurance through their jobs and that sort of thing. So, and my final question, thank you, Mr. Chair, for indulging me. When you're talking about emergency relief and rental assistance, I know I've got landlords that are going nuts. So do people, if they need rental assistance, go to the DCBS office and ask for help? Is that where they need to go? Or?
Community Action Agency, whatever
Community
the
Action
local
Agency.
Community Action Agency is, those are the folks that have some of the funds for rental assistance.
Okay. Appreciate it. Thank you, Mr. Chair.
At this time, Chairman Bentley.
Thank you, Mr. Chairman. Thank you all for being here. I have a follow-up question and asking you, how's Senate Bill 50 doing?
Oh, yeah. I I thought I might be asked today. We're working on finishing up some of the final pieces for the RFP. We hope to get it out in August.
In August.
I want as early August as possible. I think I've said to folks here and other places, I do not want to come back to the General Assembly when you all are in session and we don't have a contract in place. So we're going to do everything we can to make sure that that happens.
Okay.
But we are proceeding. I've looked at some other states. I know Ohio has had some struggles with some of this. But as of today, we're on track to enter contract by January.
Thank
Thank you. Representative Weber.
Secretary Friedlander, thank you for being here today. I've got a question that relates to the reopening of daycares in the state. Can you give us kind of an update on how that's gone? Are there any issues that have come up? And the reason I asked that, I had a constituent contact me who was waiting for the daycare to reopen related to her job. It did, but she was told that they had a 5 p.m. closing time and that she doesn't get off work until after 5. So, and forgive me if I should have already known this, but is that a requirement? Are they required to close at a certain time, or?
No, they're not. But certainly, as with all everything about reopening has been complicated. There's no question about that. We had, in our guidance, put forward for childcare that we wanted to limit group size to 10. Basically, when you think about contact tracing for a large facility, you're much better off with a contained size. There was a recent court decision that changed that via the court decision to, I think, 20-something, but that's getting appealed, so it's all in the systems, it's all in the court system at this point. It's in a state of flux. I don't think there's any question about that. Some of the child care providers feel like the limitation of group size to 10 is difficult to implement and difficult for them to have enough revenue that it limits their revenue to the point where they're really worried about reopening. I've got some statistics. I don't have it with me. I'm sorry, but I'll send them over about how many have opened, which ones have delayed opening. I know I've seen the numbers, but I don't want to say them because I don't know as I remember them correctly. So I'll be happy to send that over here. So many have opened. Some still have not, have delayed, and some may not reopen. We don't know the full impact yet, but the capacity is limited still. It's limited less by the court decision, but we, again, are going to continue to pursue, like, making sure those guidelines work. I mean, if I were a parent, I'd want to be in a limited size, have my kids in a limited size too, just from exposure, but that's me. But we, again,
Answer your question.
Yes, it gives me some kind of idea. One request that I would ask for is, can you
make sure
provide
those
me with
guidelines
information,
work.
not today, because but at some
If
point
I
send
were
it
a
over,
parent,
so that we
you know,
can get an idea
I'd
of where
wanna be in
we're,
a limited
where
size,
we
have my
look
kids
in the
a limited size
landscape
too,
on
just
daycare. So if I could
from
get
exposure, but that-
a number of
that's-
pre-COVID-19
Answer your
daycares.
question.
Yes, it gives me some kind of idea. One request that I would ask. Where we stand kind of on the reopening. And then I'd also be interested in those that you know about that have closed their doors. I'm assuming you all would keep that information as well, so that we kind of know going forward, where do we stand on this front? Because I do hear from a lot of folks that are concerned about that. They felt like they were having to choose between care for their child and their job to be able to put food on the table and pay the light bill and just live. And so I'd kind of like to know where we stand, kind of in that landscape, how that looks. If you wouldn't mind providing that to me and maybe to the members of this committee, I would appreciate that.
I'm very happy to do so.
Thank you. Thank you, Mr. Chair.
Secretary, a follow-up question I have for that. So on slide 9, where it shows that the expenditures now are 40 million, we're awarded 67.7 million to be spent on child care and development block grant. Can you give a little detail of what that money's being spent on and how it looks?
Where I'm getting there.
Slide
8,
9.
9, thank you.
Yep.
Yes. So that funding was provided, let me see if I have my memory right. So what we did was, some of that was, we had this better lined out last time. Some of that was, so the limited duration childcare centers, the YMCAs that we asked to open up, that we're very specific around supporting healthcare workers, right, and essential workers. We paid them a little bit extra, like the difference between what our normal rate was and what they were charging. There wasn't a big difference, but we paid them that difference because we were asking them to do that for them. We also paid their workers what we called a hero bonus because they were going in the limited duration, and so we paid them a little extra on top of time stipends based on the capacity of all the other daycare centers to try to keep them afloat for a little bit. But it was 1 month as opposed to they were shut down for 3. So that got us, that was a chunk of that money right there, was most of that was spent that way for those stipends. Then we had what we called a reopening stipend, which doesn't look like, at least according to this, isn't out yet. We had a reopening stipend, which basically was helping pay for if people had to restock food, if they need to restock some or do some additional with cleaning supplies. We did that as a stipend to them. The daycare providers will tell you it's not enough, which I'm sure it wasn't, but it was what we could do. So that's how we spent that funding. And I can get you a breakdown of that, like by how.
Yeah, I'd like to see that. I mean,
Program,
it
yeah.
just, when I saw that 40 million, and like I say, I had some questions there. It seemed like an awful large number. I actually have 2 more questions, and we're going to open it up for those who are on the phone. So I want to circle back to our nursing home group. And so the PC funding, I think that was in the prior appropriations bill, I think it was like 2.2 million. So we're getting feedback that there's only 17 facilities in the state of Kentucky that are receiving those funds. And so can you answer why those 17 and why it's not being distributed amongst all of them?
So we've been working with Representative Moser, as well as the KHCF, as well as some personal care providers. We actually had a call yesterday or the day before where we kind of, it's a perfect lead-in. So we've done some of these stipends for childcare. And so using the way that we did this, we thought was actually a pretty good model. So we switched kind of how we were going to do that with the PC homes. So we're going to do a stipend type of model with them too. Now the difference is, I think now between 42 and 70, 42, so we're past the 17 now. So there are 42 personal care homes that participate in our state supplementation program. Our intent is to target those. There is some ongoing discussion about whether we expand that out to 70. So what we asked was the Long-Term Care Association to give us some feedback on whether it should be on capacity, whether it should be on the number of individuals who have mental illness, severe mental illness diagnoses. So we're in the process of working that out. We're a lot closer than we were when we were in front of Reg Review, and but we're trying to work that out with everybody. So we're doing a slightly different model, but it's because of childcare and what we did there that we realized that there was a different model we could put in place. Representative Moser, do you want to?
Moser, do you have
I'm
any
sorry.
comments you want to make? Go ahead.
Sure, thank you. I really appreciate your work on this because, you know, as you're aware, during reg review, I think I had my head wrapped with duct tape so it wouldn't explode. I was like, no, we worked so hard to get these funds for personal care homes. And I think what I didn't understand and what we didn't really catch when we wrote the budget language was that and correct me if I'm wrong, if any subsidy or any allocation appropriation goes to personal care homes or anyone who serves the severely mentally ill population, such as community mental health centers, that those funds need to be matched. And so suddenly this appropriation for $2.2 million would have become $4.4 million, or 1.1 for personal care homes and 1.1 for someone else. So that's the background. So that's what I didn't understand. That's what we need to clarify in future budget language. But I appreciate that Elizabeth and your team are kind of thinking outside the box and being creative in figuring out how to get these funds and devising a formula to get these funds out to personal care homes because we know it's very needed. And yes, after our call yesterday, and it was a very productive call, I appreciate it, I texted, I think, Kelly and a few of the members that I had numbers for, that I would really like to see, as opposed to just funding the 42 personal care homes who we know serve 35% or have a population of 35% severely mentally ill. I would rather see that all personal care homes who serve any mentally ill persons receive kind of a per capita basis funding, if that makes sense.
It does.
It's complicated.
Yes.
I
And
know.
it gets a little weird going
Well,
beyond the
but it
42,
could be done on an average, and we'll continue this conversation.
the
But yeah,
conversation.
thanks for your question because it is something that we're working on.
Yeah.
So,
We've made a lot of progress.
yeah, thank you.
That's great news. Okay, my last question that I have, going back to slide number 5, the 6.2% increase of the federal Medicaid assistance percentages. So my antennas went up when you said 170,000 new enrollments on Medicaid to be in the budget that primarily, oversees that and helps craft the budget for that. It's a huge expense here to the Commonwealth of Kentucky. And when you see 170,000 new people enrolling, we know that comes with a significant price tag. So the 6.2% increase, is that 6.2% increase going to cover the state's portion of what we're on the hook for? Or how's that working?
So the best way I can describe it, and Eric, you may have better words than I, but it reduces the amount that the state needs to pay. Essentially, it adds 6.2% to the federal share.
Okay.
So it reduces the state share by that 6.2%. Now, it's only on expansion.
It is not on expansion.
It's
on
only on
K-CHIP
K-CHIP and
traditional.
regular, sorry, backwards.
Okay.
So it's not on the expansion population, but it's on the traditional and the K-CHIP population. We're bringing most of the folks in because it's presumptive sort of in the traditional side. But there'll be a reckoning at the end with when we have to true up all the incomes and things like that, and the longer process to get Medicaid eligible. But at this point, we're trying to keep as much in traditional as we can.
Okay. If you all can continue to maybe feed our LRC staff in the budget office
Yes.
some of that information so we can really keep our arms around what that cost is going to look like coming up in 2021. And another follow-up, as we've seen that 170,000 new enrollments since pre-COVID, do we see that enrollment flattening off or maybe slight decrease as we've opened our economy back up and maybe people are not needing those type of assistances?
Yeah, well, so we were seeing that 8,000 per month enrollment. It went up to about 12 for a while, and this last week it went down to 6. So we, we're like watching it weekly. One week doesn't make a trend, but that was about half of what it was at its height. My best answer to you is we'll see. Maybe we're seeing a decrease in the percentage of increase, but we're not seeing a decrease overall yet. Does that make sense?
Yeah, I'm following you. Like I say, that's, members on this committee, this is something we need to watch significantly because, like I say, this is probably maybe the biggest price tag that we're going to be facing in the upcoming budget. And I think we all know that people need less assistance when they're at work and able to provide for their family. And so I think it's of utmost importance that we really watch this. I think Senator Meredith has a comment.
The 170,000, just kind of bells go off, people don't like change. And we're going to add 2 new MCOs come January 1st. I'm not sure how many people are going to be impacted that are currently under Passport and Aetna. I know Passport's around 300,000. So I'm guessing we're going to see 500,000 people at least move to a new MCO. And just wonder if there's any particular actions being taken to make sure that's as seamless and as timely as can be, because I can see, particularly at this point in time, dealing with all these other issues, that could fall through the crack and folks aren't transitioning. They may not be even aware of it. So is there going to be a special communication effort to recipients, and how are we going to reach out to those people to make sure that we've got continuity of care in this situation? Because, again, it's quite pivotal at this point in time.
I think continuity of care is going to be the biggest and most difficult issue that we're going to face over the next 6 months. There's an active appeal going on with the MCOs. There's an active appeal going on. And with that active appeal, we kind of had to stop work for a little bit, but I've sent a letter to finance to ask that we be able to continue to work through the period of appeal. So we are working. There's going to be readiness reviews and things like that we have to do to make sure systems are in place and provider networks are in place. Hopefully, once we get to the other end of the appeal, whatever that decision is, not involved, it's finance, I'll be able to give you a much more extensive answer because we are concerned about it.
Well, I appreciate that. I'm also concerned about if the appeals aren't successful, that the 2 MCOs may not be as motivated to timely process payments and may increase the number of appeals that they have. So I would hope somebody's taking a hard look at that and building some accountability into those folks, because that's concerned. But one of the solutions we could have for this is to have fewer MCOs, but that's just, sorry, I just had to throw that in.
Absolutely.
Thank you.
We tried to put some things in the contract that would hold folks accountable. We had some of that experience when an MCO left the state and left a lot of folks holding the bag, and we don't want to see that again.
So that wraps up our questions of anybody in person. If anybody can, if you announce yourself, if you're on the call and would like to ask a question, the computer system, unfortunately, is not working. So technology is great, but it always seems to fail you at the times you need it. So if you can announce yourself, and if you have any questions for the Secretary or Director Eric, we'll be fine.
Yes, Chairman, this is Representative Raymond. Can you hear me?
Yes.
Okay. Mr. Secretary, I wanted to ask you to speak a bit to additional funding and resources for our health department. If you could clarify what federal and state money has been made available to them or will be, on what schedule. And then I understand that Louisville Metro Public Health operates a little bit differently, and I wanted to ask you to dig into that.
Different sets of funding have been made available to the health departments. The biggest piece of it has been $10 million from the Big Cares funding that has gone out to local health departments to reimburse them for their additional expenses. That's been exhausted, but we're looking at re-upping that and increasing that out of the CARES funding. Again, to try to, we think that the local health departments across the state are experiencing 5 to 6 million more per month in expenses, and we're using some of the CARES fund to try to shore some of that up, at least through the end of the year, through the end of the CARES funding time. That's the vast majority of funding that's gone to local health departments, that some of these other epidemiological grants have gone. Louisville Metro is different. Louisville Metro is an independent health department, kind of has some very separate funding streams, and also through the CARES Act, Louisville Metro government received some funding just directly, not through the state at all, but directly from the federal government on the CARES Act. So as an independent health department, one difference in their status, and then as really a part of Louisville Metro government, we've been looking for Louisville Metro government to provide the funding for the local health department through the CARES funds, as we've been doing for other local health departments across the state. And that's the best way I can do that. Is that helpful?
Thanks.
Okay.
Thank you, Representative Raymond. Does anybody else on the call have any questions? Doesn't sound like we have any more questions. Secretary and Director, I appreciate your all's presentation. I know there's going to be lots of questions as we go throughout the year. I know that some of the expenditures, you know, how you do your invoicing, if it's accrual or cash basis, and when it comes in, seeing those expenditures, I know it's a great concern to this committee as we try to craft a one-year budget coming up. And so we appreciate your presentation and your willingness to get us the information we requested. So before we adjourn, there will be no August meeting. We're going to push it to September 16th, and Chairman Bentley will be chairing that meeting, and staff will be getting out the information that meeting is going to be held on and what we're going to be covering. But anybody that's on the call, we are going to have to take roll a second time. And so, Mr. Secretary, can you call the roll for those that are on the call?
Senator Rocky Adams, Senator Carroll, Senator McGarvey, Senator Meredith, Representative Bowling, Representative Frazier, Representative Gibbons-Prunty, Representative Raymond,
Here from home.
Representative Sheldon, Representative Stevenson,
Hi, I'm here in my annex office. Can y'all hear me?
yes, thank you, ma'am.
Thank you.
Representative Weber, Representative Westrom,
Yes, I'm here at my office.
Representative Wilner,
Yes, here at home.
Senator Humphreys, Senator McDaniel, Representative Moser,
I'm here in person.
Representative Reed, Representative Rudy, Co-Chair Bentley, Chair Castle.
All right, before we adjourn, Senator Meredith has requested to make one more comment.
Appreciate your comment earlier about, we had an MCO that unexpectedly left our network back in 2013, 2014. That was painful for a lot of people. And I believe that maybe, an ounce of prevention could be beneficial. Is there any consideration to possibly having the Department of Insurance and the Attorney General send the affected MCOs a letter saying, just a reminder that, they have obligations and that they're expected to be held accountable for those obligations? Would you consider that?
Absolutely, it's a good idea. I think we should do that.
Thank you, I appreciate that. Thank you, Mr. Chair.
Do I have a motion for adjournment?